Welcome everybody. As I said, my name is Eric Tranby. I'm the Director of Analytics and Data Insights. Joining me today on the call is Becca Preston, our Project Coordinator, reviewing, as well as Lisa Heaton, our Science Writer, is doing operating things a little bit behind the scenes. In terms of some housekeeping, so next slide, please, Lisa. In terms of some housekeeping, just to make sure that background noise is minimized, we're going to be muting all lines. We're working on that. This is kind of in our presentation or webinar mode. Obviously, typically we have several hundred people that 10 or so on the webinar, but the tools work for us. Where you have any questions for us, please utilize either the Q&A or the chat functions to send questions along. Chat will be able to be seen by everybody, as well as some of the Q&A features. So the Q&A features will be seen once we've answered the questions. Chat can be seen by everybody on the call. So please, as we're walking through the call today and the review today, ask us any questions in either of those two sections. We'll also be disseminating a copy of the slide and a link to the recording to everybody registered for this webinar, so you have the opportunity to review at your leisure. And we'll be making the slides and the recording available on our website and on the landing page for this request for research proposals. Thank you, Becca. Next slide, please. So a little bit about us, if you're not aware who CareQuest Institute for Oral Health is. So CareQuest Institute is a larger nonprofit organization where we're working together to build a future where every person can reach their full potential through oral health. Next slide, please. We do this through 5 areas of activation and some other areas of influence as well. So our full portfolio, includes research, which is primarily the area that I lead, along with our robust team of analysts and data engineers and science writers and health science specialists coming together to produce and disseminate research that makes an impact on the community. And we'll talk more about that in a little bit. We also have health improvement programs that work directly in communities and with states to improve oral health care. We have extensive grant making and philanthropic efforts all the way from the national to the grassroots level. Policy and advocacy making, advocacy work primarily at the federal and state levels, and then our education programs designed to provide educational opportunities for clinicians and oral health providers across the space. We also influence in the areas of dental benefits, and we have our CareQuest Innovation Partners team as well that invests primarily in new technologies. Next slide, please. We aim to do this we aim to advance the space in part by being mission driven and values led. Our core values include innovation, collaboration, equity, and leadership. You'll see throughout the course of these proposals. I hope that you find us that we'll be working with you in a collaborative nature, and that we're working to identify the most innovative projects and use of our data with you all. Next slide, please. Our research, so if you got your phone, you can scan the little QR code. We've got a number of QR codes coming up. We'll also make sure you've got links to all the materials. But we engage in a variety of research activities, self-publications, promotions of peer-reviewed manuscripts, presentations at academic and advocacy conferences, state-level conferences, dashboards, working directly with clinics. And so a wide variety of things that we do to create and disseminate actionable research and analytics, as well as evaluation that aims to improve the oral health system for all. This research is largely powered by state and nationally representative data sources. We'll talk through a few of those data sources today, but include things like health claims data, integrated medical dental databases, and surveys of health care experiences. We also seek out by seek out and analyzing these data resources, we work to uncover trends about the oral health care delivery system and make meaningful contributions to the knowledge base through publications and presentations. These are all things that we're hoping to work with you all on this call to identify new researchers to collaborate with, providing access into our data resources, and supporting you in publishing one or more publications from these resources. Next slide, please. So what's the purpose today? So as you saw, since you're registered for this webinar, CareQuest Institute has released a request for research proposals. This request is meant to invite researchers to apply to utilize our data resources, and we'll be talking through some of those data resources shortly, to complete a peer-reviewed publication with yourself and your partners and any PIs or other partners you have as lead authors, and potentially one or more members of the CareQuest Institute team as authors as well. And make sure that publication is in alignment with CareQuest Institute's mission. So the key activity we're engaged in here is working with you all to pull together some research proposals, be submitting those proposals to us. We'll be selecting hopefully 5 or so to be supporting this calendar year, accessing into that data, doing analysis on that data, preparing a publication and submitting for publication with the goal of getting these published sometime in 2024. So kind of high level what we're going to be doing today or doing over this year. Over the course of the next 20 minutes or so, we'll be reviewing the data resources that are available for use, as well as talking a little bit more about the application process timelines and what we're looking for in these applications. Please ask at any time questions in the Q&A or the chat so that we are able to answer them in real time. Alternatively, if you have questions after, we'll be making sure to give you people that you could contact with. You could reach out to myself or Becca Preston, or there's also places to reach out for general feedback as well. All right. So now that we understand the premise a little bit on accessing the data, let's talk about what data is accessible by you all as researchers. So it includes some of the key focus areas of our work. So broadly, we're interested in proposals that build on population oral health research, broadly defined. So population research broadly. Research that focuses on oral and systemic connections and or medical dental integration. We'll talk about some of our integrated data that allows that to happen. Better classify and predict oral health outcomes. With this data, we have data going back at minimum 5 years, and in many cases longer, up to 9 or 10 years on certain patients. Evaluate alternative care approaches to improve patient access. Evaluating value-based care approaches. Understanding factors that influence oral health equity for historically underserved or vulnerable populations may include populations on Medicaid, racial or ethnic minorities, folks with social determinants of health factors, or at low incomes, have intellectual developmental delays. So broad swath of ways in which you can define underserved or vulnerable populations. And then finally, promotion of public policies that aim to increase access to and affordability of care for said populations, especially safety net clinics we have a particular focus on. Next slide, please. All right, now diving into the available data resources. Sorry, I got ahead of myself for a second. 4 primary types of data that we're making available for access to researchers through this request for proposals. So the first are integrated medical and dental claims data. This data comes from various sources, including third-party Medicaid and commercial insurance claims, our primary data sources. Data elements in this data include patient demographics like age, race, gender, state of residence, reason for eligibility, or family status. So for at least for some of the data, we're able to connect parents with children and immediate family members with each other. And includes traditional elements of claims data like dental claims, outpatient claims, inpatient claims, prescription drug, long-term care facility, diagnosis codes, procedure codes, length of stay for inpatient admissions, cost of care. So a wide variety of information. We have information on tens of millions of Americans, so 28 million unique patients that we've combined medical and dental information on with about 3 billion unique claims here. In terms of timeline, this data covers about the last 5 years. So for about the last 5 full calendar years, we do have some data resources that go all the way back to 2010. And in general, you can follow patients for between 5 and 10 years, depending on enrollment eligibility. Obviously, the further you want to follow patients, the less fewer patients there are that are continuously enrolled. But they're given the relative size of the data set, a lot of opportunities to drill down into particular comorbid conditions, to follow particular types of patients over time. That could be used with this kind of data. Where you have particular questions about the data that's potential data that's in here or possibilities with it, please don't hesitate to reach out via email directly, or put those questions in chat where applicable. We've asked a variety of questions with this data and have analyzed it in a variety of different ways. Some publications are shown on the screen here and include things like non-ventilated or hospital-acquired pneumonia, or association between well-child visits and dental preventive visits, or association between things like medical comorbidities and preterm birth outcomes that take into account dental treatment for mothers. So huge variety of things that we could do, and that's feasible to do with this data. I just wanted to give some examples here. Next slide, please. We also have direct dental claims data. This comes from a wider variety of resources, but is a little bit more limited since it's just dental claims, but includes information or dental data, but includes information on Medicaid and commercial claims, as well as some direct EHR or practice management software extractions from clinics who participate with us in research activities. So patient demographics includes age, race, gender, and state of residence. Dental information includes CDT codes, tooth and surface level information, some provider characteristics, sublocation, and obviously as well, then we have long claims history going back 5 to 10 years, depending on the particular patient. Here we have more patients, 33 million Americans, 476 million claims, and about 130 million visits, again, over the last 5 years. So very large data sources. Have, again, done a lot with this data, tracked industry trends over time, looked at oral healthcare spending over a patient's, over a lifespan, at least from a cross-sectional perspective. Used emergency and urgent dental visits, looked at types of visits, and then connection between the age at which patient first receives their dental visit and subsequent dental treatment needs. So again, because we have more limited, because it's just dental data, but we do have long claims histories, relatively long for some of these patients, and very large data sets. So definitely an opportunity to look at rare events. Next slide, please. Healthcare cost and utilization project data. So this data is data that we have purchased from Healthcare Cost and Utilization Project and licensed. We can make this data available for research for outside researchers with some data use updates. So relatively easy process. If you chose to utilize this HCUP data, you'd have to go through, I think it's about 30 minutes of training directly from HCUP and sign a form that comes to us. But this healthcare cost utilization project data covers emergency department, some inpatient and ambulatory surgery patient as well. We've largely used this data to track emergency department visits for non-traumatic dental conditions, but could include research on inpatient admissions or ambulatory surgery as well. Key data elements include visit and diagnosis rate, states, demographics, chargers and payers. We have about 10 states and some tracking long periods of time. For example, I think Arizona, we have 9 or 10 years worth of data, but at minimum have 2 to 3 years of data for each state, and as well as the National Emergency Department sample that's available for access. Look at a couple questions in chat to take us backwards. So if you could go back one slide, Lisa. So a couple questions about the claims data that we have access to. So the dental claims data. So 2 questions. One about coverage across all 50 states, and then others are these similar to market scan data, and do Medicaid claims span several states, and are they identifiable? Answer both questions. Yes, we do have information that comes from all 50 states. Some of them are better covered than not. So this data is the dental claims data in particular is an abstraction, is a aggregation of a couple of different claims data sources that we have access into. So so state is generally available on the dental claims, and we can be doing some comparisons across the states. So yes, all that information will be available. Medicaid claims do span several states, yes, and the states are identifiable for, again, some of the aggregated data sources. We will have some. I think you asked this one. The market scan data is part of the data that's available in here for Medicaid. Those don't have data. Those don't have states identifiable in them, but we do have a mixture of other claims data sources that would be available and would identify state. So for a good portion of the data, states available and available for comparison. Another question came in about dental claims data having the prescription data. So the dental claims data itself does not, but if we go back one slide on the integrated data resources, those do. We have prescription information that we can link to those. That prescription information then includes things like date of prescription, drug that's being prescribed, how much is being prescribed, and length of prescription. It unfortunately does not include information on what the prescription was, the diagnosis code for the prescription, so what it was used for. And so in some cases we're connecting data and making sure we're eliminating alternative reasons or alternative providers who could have done a prescription. But in general, we do have prescription data we can link. Keep those questions coming in. Great questions. All right, let's go to slide HCUP data. I think I covered. Again, we've done a lot of publications on things like emergency department visits for non-traumatic dental. If you have an interest in, but there's still things to mine in terms of that space, particularly focused on demographic or racial groups, or drilling down into particular kinds of diagnosis codes, or times of access. If you have a particular interest in doing not just emergency department visits, but drilling down into ambulatory surgeries or inpatient admissions, Those are things that can be done either with these HCUP databases or or the integrated claims databases. So we'd be really happy to get one or more proposals along those lines. All right. Fourth data resource we have available to us is our State of Oral Health Equity in America survey. This is a large omnibus survey of consumer attitudes, experiences, and behaviors related to oral health. It's a repeated cross-section survey, so we cannot track patients over time, but can generally track trends over time, given that's a representative sample. We collected data in January to February of 2021, 2022, and we're in the middle of data collection right now for 2023, but those data resources would be available. On average, we collect information from about 5,000 American adults per year, and so cumulatively, final sample size around 15,000 over the last 3 years. Depending on if the same question was asked all 3 years or not, there's a core that gets asked and then things that rotate. But a lot of information and attitudes on things like oral health status and knowledge, so self-reported oral health, self-reported oral health symptoms, self-management of pain, information on HPV, oral health care experiences on things like patient and provider concordance, experiences with dental anxiety, interprofessional attitudes towards interprofessional care like value-based care or teledentistry, and then questions on social determinants of health like food security or insecurity, experiences of discrimination, insurance status, experiences of losing a job, or self-reported chronic conditions. And so the way I like to say this is that our claims resources are exceptionally deep. We have millions and millions of patients, but may not be very wide because they just cover claims and people's experiences in the medical or dental office. That's obviously a small swath of their lives. These kind of surveys that we do then are very wide, but are self-reported data, so as in particular deep that we have. So it's kind of thinking about the different approaches that you may want to take. Another question on linking the survey data, claims data, unfortunately not. That would be the dream state. That's something that we're continuing to work on, but at this time they're separate resources. Keep those questions coming in. We'll kind of pop to answer them, but that's a high-level overview of the different data that's available for use for this request for proposals. In terms of a process for getting you the data, we'll walk through the proposal process, but we do imagine this is a collaborative exercise. You'll be working with our data engineers and analysts on refining a research proposal against data that's available, making data available to you in the form of a data sandbox that you're able to analyze on your own and work with some of this data for publication purposes. Some of this may also include support from our data engineers and analysts, just depending on the particular project. But with that, I'm happy to pass it to Becca to cover a little bit more of the logistics of submitting your proposal, and we'll be spending some time at the end for additional Q&A.
Thanks, Eric, and thanks everybody for joining us today. Like you said, if you have any questions, please feel free to put them in the chat or send them through the Q&A. And I also put my email and Eric's email in the chat box too. So applicant eligibility, to submit a proposal in response to this request for research, you guys should be affiliated with an accredited university as full-time research or teaching staff. If we've worked with you before, or you are at a hospital of sorts, we welcome you to submit as well. Have a solid track record of conducting analyses and producing peer-reviewed publications. Have the expertise and technology available to analyze and report on large healthcare data sets. And just to reiterate what Eric just said, we do have data engineers and analysts on staff, and we'd be happy to share their expertise if they're needed. CareQuest Institute is able to fund applications up to $10,000 for indirect costs only. This does not include funding for faculty or staff salaries or buyout time. You all should describe the requested indirect costs as part of the application. Some of these indirect costs, I mean, IRB fees, laptops, publication fee costs, anything of that sort. And if you have any questions for clarification, again, just please reach out to me. In addition, awardees may be eligible to apply for a grant through CareQuest Institute to offset some of these direct costs. If you're interested in additional information for our grants team, I'm happy to connect you. They are fantastic. They've worked with some of you on this call already, and I know that you all feel the same way about them. But I'm more than happy to connect you for additional information of the grant process through CareQuest Institute. Next slide, please. For the proposal itself, we're asking you to develop a research topic and question in line with your research interests, as well as one or more of the research and data focus areas that Eric previously discussed. Please provide a description of the intended and anticipated impact of the report, including potential publication and presentation outlets, such as, what type of conferences are you planning on, a webinar, what type of publication journals are you looking at? The journals include both oral health, public health. We're always trying to branch out of oral health because we all know oral health is overall health. So we're not just, anything on the journal and presentation front, we would welcome you to provide the description of. Proposals should be a total of 4 pages. The proposal itself should not exceed 3 one-sided pages, and then the indirect cost should not exceed 1 page. Proposals should be submitted as a Word document or PDF to the analytics@carequest.org website. That email does go to Eric and myself. So if you have any, questions with your submission or anything like that, that email does come to our inbox. So it's not going to a third party that isn't super familiar with the process. We kindly ask that proposals are due to us by March 24th at 5 p.m. Eastern time. We understand a lot of us will be at a conference during the previous week, so we wanted to extend that a little bit past that. Next slide, please. For the proposal structure, we're asking that successful proposals follow the general abbreviated structure of the NIH SF424 grant application. And we ask that it includes the following sections: specific aims, such as the goals of the proposed research, outcomes and anticipated impact, significance, description of how the research will address a particular problem or barrier, similarly to how we discussed at the beginning of this call, innovation, approach. This is how the research will be conducted, the types of data sources you want to use, the types of analysis or analyses to be conducted, and then the anticipated outcomes of those analyses. Resources and environment, facilities, the research team, PIs of that sort, and that goes into personnel, and then budget and justification. Researchers submitting approved proposals will then be invited to submit a much more detailed analysis plan following their acceptance. So we understand that as hypotheses develop, so do our analysis plans, and we get that the initial submission isn't, quite the full picture. So once if you're upon acceptance, we'll invite for a fuller analysis plan. Next slide, please. Going back to the NIH evaluation criteria, we will be using the scale right here to the right on the slide. Intended and anticipated impact in alignment with CareQuest Institute's research and data strategy will also be considered. And again, that's at the beginning of this presentation and also on the existing request for proposals too. Next slide, please. Timeline. So we are currently accepting proposals as of last week. Please submit your proposals anytime through March 24th by 5 p.m. Eastern Standard Time. We will make awards announcements on April 28th. And then the analysis plans for approved proposals will then need to be submitted by June 1st. We do have September 1st for draft manuscripts and December 1st down for the manuscript submittal, but we do, going back, we do research regularly. We understand that sometimes there's no results. Sometimes we need to expand our inclusion criteria. So those last two dates down there are not hard set in stone, but are to be sort of observed as we go through the process. Next slide, please. For additional inquiries, scoping meeting, you have questions about our data, anything else such as indirect costs, please contact Eric. His email is right there. And then please contact myself. My email is right there. And again, the submission proposal should be submitted as a Word document or PDF to analytics@carequest.org. I think that is it for me. Eric, do you have any closing remarks?
Nope, just holding on, see if there's any questions in the chat. Thank you for joining us. Everybody will hang out here for just a second. See if there's any questions before we drop. Otherwise, we very much look forward to your application or your questions. So question on CareQuest having data analysis people that can help with the analysis. So we certainly have people available for consultation. Given we do desire that people who submit have some data analysis capabilities, but understand that the data is quite large and extensive, so would be able to support and at least consult on some of the data analysis. So please don't let that be a barrier to submitting. We'll make decisions as appropriate, but we do have some resources available for feedback. Some additional questions on if data is going to be shared. So yes, the data will be shared with you. It's going to be shared in a remote research environment, so where you have access. You'd have access to the data in a remote data sharing environment. You'll be able to do analysis on the data in that environment. If there's a need to extract that data, for example, some specialty software that you're hoping to use in alignment, or something where your university would require that data is stored on your own servers, then you would need to factor that space or secure servers into indirect costs. Otherwise, if you're planning on analyzing the data with a traditional statistical tool, and one where you should be able to use our data environment through a direct connection with security. So we plan to keep the data as much in our own environment as possible. A couple questions about indirect costs or overhead expenses. Yes, at this time, we are not in this proposal not paying for direct costs. This includes things like salary time or reduction in teaching time, but other costs can be considered up to $10,000. Those include any overhead expenses that your university has, required costs for any technology costs that you anticipate, costs for attending one or more conferences for presentations would all be considered to be part of that work. Part of those overhead costs, as we said, we may forward your proposal onto our grants team for consideration for additional support. Cannot promise, as that's grants is a separate process. In terms of overhead, do work closely with that grants team. In terms of percentage of overhead expenses, our grants pays no more than 15%. In overhead, we can be a little bit more open to payment in that. We prefer not to pay more than 15%, but any overhead up to that $10,000 is permissible application. I like all the questions. These are great. The IRB submission fee by CareQuest. No, there's not a separate IRB submission fee for CareQuest. Our use of the data is already covered by our IRB. Your use of the data would also be covered under our IRB, although your mileage may vary depending on your own institutional IRB. Your IRB may want you to submit for secondary data analysis. If there's a fee associated with that, that would be part of that indirect expense for you to submit, but you do not need to submit through our IRB yourself. We would be covering any of that. Travel registration to meetings, they will not be automatically supported, but please access to the please add to your indirect costs as needed. And then can you send in more than one proposal is another question. Yes, please submit the proposals that you think would be relevant. We are likely to pick one of yours to choose, just so we to support, so that there is we're not asking one person to do too much. But if you have multiple topics you're interested in that you feel would be applicable, submit them all. We're happy to review and take them. All right. Seeing no further questions come in, please reach out with any others that happen that you have. Otherwise, thank you for joining today. We will get we'll get the slides and the notes out to all the registrants shortly, and we'll also be on the page on our website. In the meantime, have a great day, and we look forward to receiving your applications. Thanks, everybody.